Hi, everybody, and welcome to our module on cognitive disorders. Let's start by talking about disorientation. So when we say someone is oriented, we generally mean that they have knowledge of their name, the correct date, and the location that they are in, or the place. And you'll often see written in the charts of patients in the hospital that the patient was alert and oriented times 3. And what this means is that the patient was able to identify their name, the correct date, and the place that they were located. And orientation is lost in many cognitive disorders, and when this happens, we say that the patient has become disoriented. And one thing you should know is that the first thing people lose is time, and the last thing they lose is person. So if you think about this, imagine someone who's waking up from anesthesia and surgery. They're often a little bit disoriented. They usually will know their name, and they may even know that the place that they're in is the operating room or the recovery area, but what they will not know is the time. They will have trouble telling you what time of day it is. So time is the first thing that gets lost, even with a mild amount of disorientation. In order to forget your own name and not know who you are, you have to be severely disoriented, so that's the last thing to be lost, and then place is somewhere in the middle. And shown on this slide are some of the many causes of loss of orientation that you'll see on your clinical rotations. Patients who are febrile or infected can be disoriented. Patients who have consumed alcohol or drugs may be disoriented. Hypoglycemia and electrolyte abnormalities can lead to loss of orientation, and so can many, many other medical conditions. In addition, cognitive disorders like delirium and dementia, which we'll talk about later in this video, can also lead to loss of orientation. Now let's talk about amnesia, which is a loss of memory, and it's usually caused by some type of central nervous system or brain injury. For example, patients who suffer a major concussion can potentially develop amnesia. And there are two types of amnesia, retrograde and anterograde. So in retrograde amnesia, patients lose memories from the distant past. For example, someone with retrograde amnesia might forget where they grew up or how they spent their childhood. But going forward, after the CNS injury, a patient with isolated retrograde amnesia can still make new memories. So for example, if a week ago a person had a concussion and they have retrograde amnesia, they'll remember things from the recent past over the last week because they're still making new memories. It's those remote, distant memories in the past that they have lost. In contrast, in anterograde amnesia, the patient can remember things from their past, like where they grew up or how they spent their childhood, but they have an inability to make new memories following a CNS injury. So a patient with isolated anterograde amnesia after a concussion might be unable to make new memories. So each day after the concussion, they keep forgetting what happened the day before. They're not making new memories, and they are forgetting things in the recent past. And just an aside here, but in the video on dissociative disorders, I talk about dissociative amnesia. This is a special form of amnesia that's very different from retrograde and anterograde amnesia. Dissociative amnesia is not caused by a CNS injury. It's caused by some form of psychological trauma or stress. So patients with dissociative amnesia will suffer a psychological stress and subsequently forget autobiographical information like where they live and what their job is. That's a very unique form of amnesia, and you should never confuse it with retrograde or anterograde because it does not follow a CNS injury. One of the classic causes of amnesia that you should know for step 1 of your boards is the Wernicke-Korsakoff syndrome. So Wernicke syndrome is an acute encephalopathy. It's an acute brain condition where patients can become disoriented or lose their memory. Korsakoff syndrome is a permanent neurologic condition that's usually a consequence of Wernicke's encephalopathy. So if a patient experiences multiple bouts of Wernicke's encephalopathy, they then can go on to develop a permanent neurological condition called Korsakoff syndrome, and we call this collectively the Wernicke-Korsakoff syndrome. Both of these are associated with thiamine, vitamin B1 deficiency, and alcoholism, and they're commonly seen among patients who are alcoholics, who are malnourished, and don't get enough thiamine in their diet. It's very high yield to know that Wernicke-Korsakoff syndrome is associated with atrophy of the mammillary bodies in the central nervous system. The mammillary bodies are shown here in this picture. They are an element of the limbic system. So the way that Wernicke-Korsakoff syndrome usually develops is it's usually in an alcoholic who suffers from thiamine deficiency. That patient will develop a number of episodes of Wernicke encephalopathy that improve after thiamine is replaced. However, if they have a number of episodes of Wernicke encephalopathy, they then can potentially develop the Korsakoff syndrome, which is permanent. And once they develop the Korsakoff syndrome, they will have the clinical features shown on this slide. First of all, patients with the Korsakoff syndrome classically confabulate. This means that they make things up because they have amnesia and they can't remember facts about their life. So they don't remember what they did yesterday or last month, so they make up a story. They also tend to be apathetic. This means they show a general lack of interest or concern about the things going on around them. Their personality may change and they may develop amnesia. That's why we're talking about this now. They typically develop antegrade and retrograde amnesia. Usually there's more antegrade amnesia, but you can see both forms in patients who have the Korsakoff syndrome. Now let's talk about cognition. Cognition is a mental process that involves acquiring knowledge and understanding things. And in order to have cognition, you must be able to integrate your thoughts, your experiences in the past, and also information from all of your senses. So in cognitive disorders, there's a problem acquiring knowledge and understanding things. Basically, patients have problems processing information, and this can lead to disorganized thinking. It can also lead to disorientation, like we talked about at the beginning of this video, where patients aren't able to tell you the time or place, or in severe cases, even their name. And the two classic cognitive disorders are delirium and dementia. So both dementia and delirium involve problems with cognition. In other words, problems acquiring knowledge and understanding things and disorganized thinking. So how can you tell the two apart? Well, dementia is a chronic progressive condition, and it's usually irreversible. And the classic example of dementia is Alzheimer's disease. If you know people with Alzheimer's disease, they slowly lose cognitive function over months or years. In contrast, delirium is an acute condition. If you get a fever to 104, you may become delirious, but this is usually reversible. And in addition, delirium classically has a waxing, waning course, meaning that someone who is delirious may have good cognitive function for a period of time during the day, and then later in the day may become very confused and have disorganized thinking. Basically, their mental status is waxing and waning, and that's also different from dementia. If you've ever met a patient with Alzheimer's disease, they don't wax and wane during the day. Their cognitive inability is there all the time. So what happens in delirium? First of all, there's a loss of focus and attention. Patients in the hospital who are delirious are very difficult to get a history from because they can't pay attention to you and answer your questions. Their thinking is disorganized. They may have hallucinations. Classically, these are visual. Patients who are very delirious may think that they are seeing things. And then finally, their sleep-wake cycles are very disturbed. So they're often awake at night and they sleep during the day. And this is typical of patients in the hospital who are sick with a medical condition that leads to delirium. So along those lines, let's talk about the causes of delirium. It's rarely a primary disorder. It's usually secondary to some other cause. Patients who are infected, especially if they have a high fever, will be delirious. When the infection goes away, the delirium will go away. Patients who have consumed lots of alcohol or who are withdrawing from alcohol will often be delirious. You can see delirium on top of dementia. So a patient with dementia, like someone who has Alzheimer's, who is in an unknown setting and is hospitalized and has fever and pain, this patient may become acutely delirious. And for all of these reasons here, delirium is one of the classic and common causes of altered mental status in the hospital. When you see someone who is confused and disoriented in the hospital, it's often because they are delirious, secondary to some medical condition. An EEG or an electroencephalogram is a recording of the electrical activity in the brain. It's similar to the EKG in the heart. So the idea here is that you put leads on the patient's head and you record voltage changes in the brains. And there are different leads that examine the electrical activity in the frontal lobe, parietal lobe, or occipital lobe. And there are characteristic patterns that can be seen in various neurologic disorders. But one thing you should be aware of is that the EEG is normal in a patient with dementia and abnormal in delirium. You can just think of delirium as the patient's brain sort of going haywire from an infection or another medical condition. So because of this, obviously the EEG is going to be abnormal. In dementia, there's a slow, steady cognitive decline, and the EEG does not become abnormal. The best treatment for delirium is to fix the underlying cause. So if a patient is infected or withdrawing from alcohol, if you can make those things go away, the delirium will get better. If the patient's hypoxemic or in pain or volume depleted, just fix those things and the delirium will improve. In addition, it's helpful for delirious patients to put them in a calm, quiet environment. If they're in an unfamiliar setting with lots of noise and activity, this will just make people more agitated. And then if these things aren't possible or they're ineffective, then sometimes drugs are used. Haloperidol, which is an antipsychotic, is sometimes called vitamin H because it's used in the hospital among patients who are delirious. Now let's talk about dementia. As I mentioned earlier, in dementia, the decline in cognition is gradual, usually occurring over months or years. And this is in contrast to delirium. You may develop a fever and over a matter of hours become delirious. Dementia doesn't follow a course like that. It occurs very slowly over time. In addition, with dementia, there's no change in level of consciousness. Patients who are delirious can sometimes slip in and out of consciousness, but you won't see that in dementia. And also in contrast to delirium, dementia is usually irreversible. Most of the causes are things like Alzheimer's disease, which don't have treatments and cannot be reversed. And patients with dementia have problems with cognition, so they will present with memory deficits. This is often an initial complaint. Someone will come into the office or they'll be brought in by a loved one with a complaint of forgetfulness. Impaired judgment can occur, and even in the later stages, personality changes. On this slide, I've listed some causes of dementia. Alzheimer's disease is far and away the most common. The second most common is multi-infarct dementia. Basically, these patients have multiple strokes that destroy their cognitive function. Lewy body dementia is a type of dementia that involves movement symptoms like Parkinson's, and that can cause dementia. And then finally, there are rare disorders. I talk about Pick's disease in the dementia video in the neurology section. I talk about normal pressure hydrocephalus in the neurology video on ventricles and sinuses. Creutzfeldt-Jakob is a prion disease. HIV in the late stages can cause dementia. Vitamin deficiencies, especially vitamin B12, are causes of dementia. And then finally, Wilson's disease, which is a copper storage disease, also classically leads to dementia. I'll finish with this slide and briefly mention the workup for new onset dementia. So patients who develop dementia often come to see their doctor. The patient may come his or herself and complain of memory problems, or more often they're brought in by a family member who says that my loved one is starting to forget things and get confused. So what type of testing should be done? Well, first of all, it's been well described in the literature that lots of screening and testing is low yield. So these people in general don't need MRIs and a big complicated workup. There are a small number of treatable causes of dementia, and those are the things you should look for and exclude. Remember, as I said before, most patients will have Alzheimer's or multi-infarct dementia, and those disorders are not treatable. So what are some of the treatable causes of dementia? Well, first of all, depression can present with dementia-like complaints. A patient who is lethargic and lacks interest in things and seems confused may be depressed, and you need a screen for that. Hypothyroidism can also lead to dementia-like symptoms, so a TSH is often checked. Beyond these two things, most testing is low yield, and it's only done if there's a special reason. So neurosyphilis can lead to dementia. If you have a reason to suspect that, you could check a RPR. Vitamin deficiencies like B12 can lead to dementia, so a B12 level is sometimes checked, and the same is true of HIV. If there's a reason to suspect HIV, you can test for that. And that concludes our video on cognitive disorders.